All right.
So those are some examples.
Right. I'm seeing a question in the chat from Lamar Campbell. Are there other sporting events that see major transduction similar to javelin throw? So I
I'm
guess
sorry,
there's more thing.
can you say that again?
Sure. Are there other sporting events that see major transduction, I guess a mechanical transduction, similar to the javelin thrower, based on what you're
Oh yeah, yeah. I would say Stefan Holmes high jumper
ah,
his ankle stability, at his height and what he's done, major transformation, mechanical transduction. And I think no one has exemplified that greater than Stefan Holm
okay.
in terms of, say a different part of the body,
Right.
strengthening it through that. And every athlete, I mean, Patrick Mahomes, who's a very successful American football player, probably the most successful American football. His whole body has been trained in a way of focusing on his connective tissue. That's why he's able to throw a football with his feet not even being on the ground. I know his trainer pretty well, and he actually is speaking at our conference coming up. We have a conference in 2 weeks. We're
Okay.
putting on called the Fascia Training Summit. So yeah, these are all different types of things that I'm showing you on my screen. Uh, Loading vectors from different angles are going
Right.
to address the fascia system. So these are all types of drills that are going to activate the fascia system to cause the system to co-contract and auto brace. So it's auto bracing is what we're trying to get out of these types of movements that we have, with a strap going around the core, and we're doing different hip flexion and extension movements. But your left glute is on fire right there to
Mhm.
stabilize. Your core
Right.
has to
Right.
activate. There's a
Right.
lot of things going on in this motion by changing the vector forces through the system. That's the takeaway, changing the vector forces. And that's what I want you guys to walk away with.
Awesome. 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 Thank you so much, Bill. That was very interesting and informative. We
Dr.
thank
Hansen,
Excuse me,
question.
I had my hand up.
Dr. Hansen has raised his hand.
Okay. Sorry, I didn't see.
You can go ahead,
Can
Dr.
I go ahead?
Yes, you can.
Good afternoon. Very interesting presentation. I just wondered about the application of this technique to people who have collagen vascular disease. And I see where this the speech is geared towards sports, but does it have wider application to people with collagen vascular disease?
You know what? That's not something I've done a lot of investigation about with collagen. Did you say collagen vascular disease?
Yes,
Yeah,
conditions like scleroderma, lupus,
Lupus and
rheumatoid
stuff.
arthritis,
yeah, yeah.
spondylosis.
Yes, I would say I am not qualified to answer that question. I have not done this type of training with anyone with uh, those types of diseases. I would say, but with that said, I would say just omnidirectional movement, even without loading or very, very light loading,
Mhm. Mhm.
just everyday movements with a very light load, like a, you know, 5 pound medicine ball or 5 pound object, and just loading the system and moving through different ranges of motion. I don't see how that would hurt, but I would start with very light to try and get the body to respond to those loads. Because when you hold a load away from your center of mass, your body has to co-contract a number of muscles to stabilize. Now, if you move with that load away from your center of mass, now you have to dynamically stabilize. And health and movement is about continuous dynamic stabilization and controlling the degrees of freedom that our joint system has. Athletics and sports just exacerbate that. In terms of it becomes very, very more demanding in sport than everyday life, right? So to be an active and healthy human, you have to have some athleticism to yourself, to your ability to stay healthy and active and to be able to function. So hopefully, I'm not sure if that answers your question, but hopefully it does.
Well, I would say I could see the application of this to just everyday rehab or even people who are like construction workers, manual laborers. I could see the concept being applied there. So
Oh,
yeah,
what 100%, because construction workers and everyday workers, that's what they do, you know? I mean,
right,
that's really important. And sometimes they'll get injured, you know, on the construction site because they're actually maybe overdoing one type of motion, right? So they might get
right.
injured. So they're
Yes, correct.
overdoing one type of motion. So we have to re-engineer their motions to get them healthy, to create balance and symmetry. Because what happens is, if you can see me, what happens is one of these elements of tensegrity get really tight. And when something gets really tight, something else gets really loose and you have an imbalance. And you have one area of the joint tight and the other area becomes weak and loose. And that's where an injury occurs.
All right, guys, thank you for that vibrant discussion. We do have to move on to our next speaker. So thank you again, Mr. Bill, and all the questions you guys have asked. We are next going to move on to our, what I call the visionary duo, Chris and Frederick. Now, Anne Frederick is a professional dance teacher, holds a degree from the Arizona State University in academic dance with a special focus on kinesiology and biomechanics, who later started her private practice of her brand of assisted stretching, which is now called fascia stretch therapy. Her innovative approach led her to become the first flexibility specialist to work at an Olympics, starting with the men's USA Olympic wrestling team in 1996. Chris Frederick is a physical therapist for over 30 years, specializing in general orthopedics and sports with a subspecialty in professional dance physical therapy, joined Anne in her mission. Now, together, they established the Stretch to Win Institute. They've written 2 books, Stretch to Win and Fascia Stretch Therapy. They are contributing authors for several other books to include, but not limited to, Fascia, the Tensional Network of the Human Body, Fascia in Sports and Movement, and Fascia Function and Medical Application, just to name a few. Now, with their extensive experience in fascia-focused therapy and flexibility training, they have worked with elite athletes from the Arizona Cardinals, the New York Giants, the Philadelphia Eagles, and the Seattle Seahawks Super Bowl teams, and the USA Olympic track and field team. And finally, they also have presented at multiple national and international professional research conferences. So please help me to welcome Chris and Anne Frederick.
Thank you. Thank you. Can everyone hear me?
Thanks, Marlene.
We're all good, Marlene?
Yeah, you guys are good to go.
Right.
Okay, thank you for the invite. It's an honor and a pleasure. Let me just get this to Playwright here. Play the slideshow. Okay, everyone. Hope everyone's having a great day, and hopefully we'll make your day a little bit more interesting. We titled it To Stretch or Not to Stretch. There was a period of time where stretching was very controversial. Either you're for it or against it, and probably still is. We're going to talk about, but it's more about the optimal tension. So it goes back to what Bill, who did a wonderful presentation when he talked about tensegrity. It is about the tension integrity. That's what tensegrity means, and we'll get into that. All right. We'll just introduce ourselves. I'll let Anne talk a little bit here.
Well, I think one of the things that is always interesting is when we create a technique, and my whole philosophy is if it doesn't apply to performance and function, it doesn't do you any good. And from the beginning, that's where I was with athletes from the university setting and then the Olympic setting, and very quickly into the track, just because speed is directly impacted by the mobility of the body. So that's where that came from. The other thing that I find very important is to have lots of different ways to rev up nervous systems and calm them down. And we'll talk a little bit about that and show a little bit about that. We also are research-based, and as Marlene, who's one of our students, one of our actually in the very first level 4 group last September, yahoo, is to pass the baton to what we're doing. So for me, it is a absolute honor to be asked to present, and I love the opportunity to work with my husband. So take it away, Chris.
Well, actually, it's still about you.
Oh, well, you talk about me. No? Okay. All right. So it started many, many moons ago, 1996, actually a little prior to that, where they gave me all 26 teams of the university and said, okay, figure it out, go. And let me just start to have an opportunity to work with all the different kinds of athletes. And like I said, if it doesn't transfer to function for athletes, it doesn't do you any good. So that's kind of, I was put under the gun out the gate on the beginning, and I love that. I'm also very research-based and have done quite a few studies. So to me, the validation of the science is really important as well.
Hello, everyone. I'm a physiotherapist. In America, we say physical therapist, same thing. In '99, I joined Ann at the clinic, and so I started integrating her work of fascia stretch therapy with physical therapy, and I discovered a lot of really interesting things, got much better results, and how to figure out how to use it in my assessment and my physical diagnosis. So, of course, I integrated with everything that was hands-on, which is the manual medicine or manual physiotherapy, integrated with everything related to sports. And we're both trained in Tom Myers anatomy training, structural integration, which is basically a very deep and very thorough whole body fascial approach to body work. We already talked about, Marlene was very nice. She mentioned the 3 Super Bowls we were at. And yes, this is one of your country women. Sanya Richards was her name. But when we knew her, then she got married, Sanya Richards Ross. You all know she was the best at the 400-meter event at a time. And she won like 10 gold medals. 4 were at the Olympics. We had the privilege of working with her at the University of Texas, Austin, on the women's track team. We worked on everybody in her from 2002 to 2008. So really, when she just got there as a freshman, which was very exciting when she won her first gold at like 19 years old. And there's a quote there from Sanya saying, I always had trouble with my hamstrings, but after working with Chris and Ann, I was able to compete without pain. I use the routines every day. They help me stay injury-free. So it was a real honor and privilege to work with this high-level athlete. We'll never forget that experience. Again, back to stretch or to not to stretch, I want to talk about assessing and balancing the tension in the system, which is the tensegrity. And just to show you how important the word tension is, tension is not a bad thing. And that's something we have to teach our clients and our athletes. There is a proper balance of tension. Too much tension is excessive. Too little tension is deficient, meaning hypermobile and lacks connective tissue, which is not good. So one of the premier books written by scientists and clinicians on the left, it's called Fascia, the Tensional Network of the Human Body. So they did mention that word tension because it is so important. And the other book, and I was honored and fortunate enough to contribute to both of these books. And the second book by the same, the biggies in fascia, in sport and movement is obviously sport specific. So there is a lot going on in the fascia world, and we thought we'd share that with you if you haven't been exposed to that. Connective tissue is the system we're talking about, but it's called fascia. That's the one word. The F word for connective tissue is fascia, and we will call it a net because it's 3D. And as you can see, we had an artist draw up the human body with the muscular system, but covered with actually a fascial net. But we need to understand it's not just around the muscles, it's in between, down deep, all the way down to the bone. I put some other words here: soft skeleton, body fiber that could be dense like the IT band or the plantar fascia, or loose. It could be viscoelastic, and Bill Parisi talked about the elastic energy, and it's also called soft matter. So just throwing out these terms for you to get exposed to, because sooner or later you will hear them. And it's just good to get familiar with these terms when we talk about fascia. We always talk about myofascia. As Bill alluded to, it's much more than that. It is viscero-neuro myofascial imbalance that we're talking about specifically. And so viscero is the visceral system or your organs. neurological system, obviously, and myofascia all together is being affected when you do this work, not just the muscle. So I'll give you an example here. We have this muscular model in the fascial net, and the blue zones are areas of, let's say, imbalance. So let's talk about, you can see the neck, but let's move down to the thoracic area between the shoulder blades, where a lot of athletes are very tight, or they complain back there. A lot of people do. So in the fascial world, we talk about fascia being locked short or locked long, just to help you understand. When it's locked short, it's under concentric forces. And when it's locked long, it's under tensional forces, eccentric tensional forces. And oftentimes it's the lock long that hurts more because it's under strain, constant strain. So if you look at the figure from the side, the front chest area, the sternum, the pecs is locked short. So it's basically in a shortened position. And the antagonist in the back is obviously the opposite, locked long. And so basically you need to balance the system out. But we'll talk about, it's not just the muscles that we're talking about here, it's other things, which we'll discuss in a minute. If you go to the low back, it's actually the opposite. The core in the front, the abdominals are locked long, and the back is compressed and locked short. And so the risks, give you some bullet points down here to think about how does this affect the whole body, because people will complain of low back pain only. Well, it's not just the low back. That's where the symptom is. And we always say it's not where it hurts that's the problem. It's what's contributing in the whole system that's throwing your back out. Same with anything else. So we need to understand fascial anatomy. It's different than just understanding muscle by muscle. It's more about the kinetic chain through the fascial system. So the risk in the neck here, I just picked out a few things. There's a lot more going on, but you're going to have downstream restrictions on the thoracic spine. So upstream, downstream is how it works. A person may complain of their neck. And if you look, the neck here is hyperextended in the subcranial region, but it's hyperflexed in the front. And so that's locked short and locked long in the front in the neck and locked short on the back. So of course, if your alignment of your head is forward, it's throwing off the whole body. And so the restrictions will just trickle on down, and therefore thoracic spine restrictions will happen. And if an athlete does have a forward head, it's really not good. If they're a runner or any kind of athlete at any time, it could decrease their performance. The next thing is thoracic, in the thorax, which is the rib cage and everything, all the organs. If that person is standing like this and kind of functions like this, they can come out of it a little bit, but they always sag and go into this position. You're going to have rib cage issues. You're not going to have rib expansion, which is breathing, which is what you want in sports like 100-meter sprint. And they got to catch up with the oxygen debt that they just got from the run upon run upon run in practice. The ribs have to expand with the intercostal muscles in between. This is under compression. Their lungs are under compression, so they don't get proper oxygenation. And of course, they have rotation restrictions. All could decrease performance. And lots of high-level athletes can muscle through this, but eventually it'll catch up. Next on down the back, it's being compressed. So the disc and nerves will be compressed, and that goes downstream. It will cut off some of the nerve supply to your legs. You don't even have to have outright sciatica for problems to develop with a shutdown. It's kind of like a dimmer switch on the light. Muscles are not on or off. It's more like dimmed down or dimmed up or normal. And so when you have any compression in the back that's affecting the nervous system with the discs, you can get some shutdown in the muscular system. And finally, in the feet, you see the way, if you look at the side view, this model is standing a little bit more on the balls of their feet. Now, in general, athletes stand on the balls of their feet more anyway, because they're in the ready to go position most times. So they're kind of, used to that. They're conditioned that way. But in this case, it becomes a pathology. They can actually get plantar fascia tension increase all the time they're standing because they never relieve it. And so if you have anybody with plantar fasciitis, the first thing I get them to do is weight shift front to back and get neutralized so that you take strain off of that constant strain on the plantar fascia. And of course, you have upstream effects with calf pulls and other things that we're all too familiar with. We're trying to get people better. So we all learned in physiotherapy, hopefully you learn about regional interdependence model. That came out in 2007. It basically showed, again, where it hurts is not where the problem is. We respect that. We can treat that. But we have to look for the connections. And so if you just look at this quickly, the top is musculoskeletal. We know that. We're always treating that. On the left would be somatovisceral, which I mentioned. It could be, visceral reflexes. We think it's the muscle, but actually it's in the organ because there's fascia there too. On the bottom, it says neurophysiological. We're very familiar with the nervous system and its connection. And the last is biopsychosocial. Obviously, it's all one person. We have to treat that whole person. But it may be emphasized in certain parts of these areas. But these photographs show basically on the bottom of that model, we see the fascia really wrapping around the organ system, the circulatory system, the lymph system. It is everywhere, and proprioceptors are everywhere in the fascia. And so just to be cognizant of that, on the upper right-hand corner, it's just showing it's kind of an artistic model of the fascia being a fiber, literally winding itself around everything and connecting everything to everything. And on the bottom, it shows you the viscoelasticity, how we are mostly 70% liquid. And, this is an important thing too. We're not solid, we're soft matter. And this is not even all completely understood. So fascia, there's science, but there's also the art of applying the right therapy. And before we show you some actual examples with Anne taking a model through the stretches so you can see it, I'll just briefly talk about the effects of fascia stretch therapy. We call it FST for short, on the whole system of fascia. So the first bullet, it balances neuromyofascial tension, not just myofascia. And I'll just say right now, there's such a thing, what I call tight nerves. It's not sciatica. I mean, there's no medical diagnosis called tight nerves, but I see people with tight nerves all the time. It's like you start a stretch and they're fine, and all of a sudden they get a negative reaction to the stretch. That usually means to me that the connective tissue around the nerve and the dural system deeper around the spinal cord, from the nerve spinal cord even to the brain, is super tight. And that's a different technique. So anyway, we balance out the neuromyofascial tension. When it's excessive, we work on the antagonist being stretched. For example, when your hip flexors are super short and tight, you know that you have to open that up to get the glutes to fire. So when it's deficient in the glutes aren't firing. The next bullet, the agonist, in this case, the glutes are the agonist and the low back, they can be activated simply by stretching the hip flexors in this case, right? And the lats are included in that. On the joint end, so that's for my neuromyofascia on the joints, we can achieve dynamic stabilization to float within the capsule. So that goes back to what Bill Parisi just presented. Bones float in your body. If they're touching, that is not normal. That's the beginning of osteoarthritis. So we can prevent that if we keep space in the joint capsule. So when they're hypomobile, we need to decompress and traction that out, not just straight on, but also work on the different angles. If they're hypermobile, opposite. You need to compress that joint while you work on them. So we will actually, if we have a hypermobile client, and I have to say, you can be hypermobile in one joint only from an injury, like ankle sprain over and over and over, like they get in basketball and other sports, that joint is permanently hypermobile. We'll talk about what you do about that when we can't help them. Versus systemically, that's the whole body. And there are diseases, connective tissue diseases called Ehlers-Danlos syndrome, EDS. They're hypermobile all over. And these kids, unfortunately, try sports and they get injured over and over and over again. And they complain of being tight and they want to stretch and they get worse from stretching. So we need to know when to stretch and when not to stretch. It's not like never stretch, and it's not like always stretch. You have to apply it at the right time for the right person. So we teach that, how to work around hypermobility. And the last thing is the nervous system. We don't stretch just to relax people. It's more about when are they getting stretched. We worked on the track. We worked at Texas Relays with UT and all the runners. We worked at the Olympic trials. You're going to upregulate them. They're going to run. You don't want them relaxing. You all know this, but there is a way to get them going without stretching anything. You're actually improving their proprioception, their feel. They want to feel their body before they go out, as you all know. And this, we can do a certain way of working on them for 10 minutes. It's not 20 minutes. It's like 10 minutes and they go out feeling great versus for recovery, resiliency, in return to get over any injuries or to just basically get back restoration. Thank you very much. We can down regulate and do a longer session. So I think now we're going to show some examples. Anne's going to start describing what she's doing here. We call this move the reverse hip opener, and I should have taken away all audio. So there we go.
So this is a video that explains a bit more detail probably than we need how to perform this particular movement. And it is something that I figured out to unlock the tight hips of the amount of folks that run that I saw. And what I discovered that if you don't unlock the deep, actually pelvic floor muscles and the deep hip muscles to get the femur to be moving in the socket, not much else is going to be as helpful. So this is a movement where I am using my body to pin and stabilize the pelvis as I take the leg through a range of motion, keeping it nice and secure, but it looks like it's something that anatomically it would not do on its own. And for me, it's one of those things that you need to go nice and slow. Marlene knows this very well. And it is very, very powerful I always refer to it as unlocking the power of the hips. So that's just a little bit of an example of that. I also think, Chris, probably from a time standpoint, what we may be better doing is moving to the game day or the pre-event with John.
Okay.
Time-wise.
Marlene said we have time. She gave us time. So
I want to make
we're
sure
good.
that we're honoring that. So
Do you want to see the next one?
sure, go ahead. Okay, the next one is more of that was a deeper, more proximal. This is more of a global. It's what we call lateral net. And I'm moving two limbs at one time. So you can speed that up a little bit.
Yep.
So it's one of those things that I'm always looking at, how can I emulate as much tissue as possible at one point in time, as opposed to the traditional concept of isolating. We know through thousands of hours of work and lots of dissections that it is impossible to isolate anything when you stretch, that actually, quite honestly, everything is connected from the outside all the way down to the cellular level. And I'm always working on figuring out how I can get as many diagonal and spiral movements simultaneously, because it emulates the way people move specifically through athletic endeavor. So this is one that I'm moving the bottom leg and the top leg into different directions. And for me, the more I can engage, the more application it ends up having to transfer to function and to performance.
So basically, I find it interesting with this movement because she works, different lines of vectors, like again, what Bill Parisi is talking about, lines of tension, lines of pulling forces, and she feels exactly where I need to be a little bit relieved of too much tightness and where I'm good. I don't need it. And that's a feel thing. You can only get that by really understanding at every point of angle what the tissue needs at that moment in time, because not everything needs to be stretched. Here we have dynamic, the work done in a dynamic fashion with an Olympic level 110-meter hurdler. He came to our class to get trained. And I'll speed that up to where you get going. You can talk about that.
Mm-hmm. Oh, okay.
He's talking about his needs, and we'll tell you, he went to train right after this, went at the end of the day, and we'll talk about the results.
Actually, I think he sprinted in the parking lot after
Okay.
that. This was at a class.
So that's similar to what you did a little bit with me, and
Yeah, it's usually my go-to
decompresses when she
short movement to
practices.
check in and see how their tissue is feeling.
There you go. So you can see when she turns and twists her body, she's getting three-dimensional. It's not just the coronal plane. She's moving into other planes depending on what the tissue needs. She's moving at a faster clip. So the athlete does not fall asleep. They stay awake.
I also learned very early on that in order to really truly be able to maximize the movement, if I could keep one leg stabilized on the table and not have to worry about holding on to it, it made for a much more productive session. You'll see I do lots and lots of rotational movement, and I'm moving quite quickly in and out of it. There's nothing static about the way we move. We're not big supporters of static movement unless you need to take a moment to let it kind of let go. But we are moving, particularly, this is more of a pre-event, pre-training tempo that we're moving at. It's more of a dynamic tempo. always looking to move and open those hips up in different directions and patterns.
You can see she changes the duration of the stretch too. There's short duration. There she went a little longer because the tissue needed a little longer, but it's based on feel and experience of what the athlete needs at that moment. So it's customized and personalized. We don't cookie cutter or standardize it. So she went from short myofascia to long myofascia, or the shorter muscle attachments to the longer attachments. That's basically, you could say, a protocol in a sense that we always follow.
Now you're going to see the reverse hip opener on
one side.
This athlete. You'll get a different angle of the dynamic way I'm moving that leg through space. This gentleman was a hurdler, so this was something he found delightful, to get somebody else to get his leg into that position. And I'm using my hip.
So you could see with the trail leg, he's getting it good with the trail leg. That's a unique, I have to say, that's a signature stretch that my wife developed. Because as a physio, I never saw that before or experienced it.
One of the other things that we believe in is going back and repatterning over again. When I've got the tissue to open up, I'll go back and layer it in to see if I get a little bit more movement and a little bit more freedom through the angles, so that I'm just maximizing the angles that they specifically need and not going through any particular custom routine that is, regardless of how the tissue is feeling, I'm always feeling what they need at that particular point in time and for what the event is. I'm going back to do that reverse hip opener one more time to see, yep, that leg drops in even better this time.
Yeah, you could just see how it opened up.
A little bit of PNF, just trying to fire it up and get them ready to roll.
Excellent. And basically, I went out with him to the track the next day,
right.
and he reported that he made some personal bests, and obviously he times everything. So he did, yeah, he definitely did a lot better after that. So I'm just going to share with you some quick tests that some of you who do manual therapy or physios, you can do really quick. So I do what's called a prone straight leg raise or prone hip extension, but honestly, it's not just the hip that's moving here, right? Because it's fascia. So on the right slide, you can see the lady's leg is higher, the left leg is lower. So the question is, where is it coming from? Is it coming from a tight hip flexor that is inhibiting the glutes, or is it coming from a glute that's too weak and back, the back and the glutes, too weak and the hamstrings to lift the leg, or is it both? So I'm just sharing with you how I go through the diagnosis and the assessment. So here I do what I call a prone straight leg raise tension release test. Honestly, I'll just tell you how to do this, and Marlene learned this. You take 3 fingers, this is the way I do it, take 3 fingers, I do a gentle release. Now I go to 3 places. I go to the iliacus first, then I go to the iliopsoas septum, which is a fascial septum. Then I'll go to the psoas, and I'm going to look for the best response. Either there, and I always ask the client, do you feel better, worse, or the same? And I'm looking at the leg, and I can see right away, if I'm on the right spot for release, the leg pops up like I just pressed a magic button. And if I press too hard, I'm going to actually inhibit them from lifting. It hurts. It's going to drop. So there is a technique to this. You got to learn it to do it right to get the proper response. And basically, I go from ASIS to the iliacus. I test that first. Is it better, worse, or the same? Iliopsoas septum, and then the psoas. And I test and I try to stick with the best response. That basically tells me where to do manual therapy and iliopsoas release or whatever it is. So this is like one technique. I always release the quadratus lumborum first on their side, because the QL, quadratus lumborum, is attached fascially to the psoas. So I can get a better psoas release if I do the QL first. Then I get over on the client, they're still on their side. The big picture on the bottom right is more my elbow. And for those of you who have never done this, it is much more comfortable to do a nice soft elbow that gradually goes into the tissues a little deeper based on the client's tolerance than it is on your back. To do the supine smash into that myofascia is not as effective as first doing it sideline. It desensitizes them. They can take the pressure, and it works so much better. Then I will test them. If they test on the lower left, it says manual muscle test. But really, we're not just testing one muscle like we learned in school. I call it a posterior chain resisted test. I'm really testing the whole chain. In the top, I may be influencing or focusing on the glutes more because my hand is a higher position. And the second picture, it's lower to get the hamstring and the glutes and the back. But if they get a 5 out of 5, they're strong. They're kind of good to go at that point. However, you will get a client, and I just changed the words up here, they're weak. So I press on them, and it's like they can lift it against gravity. That's a 3 out of 5 strength. But when I touch them and I just press down lightly, they fail the test. They're like 3 plus, right? That's it. So I know there's something wrong, most likely now in the back. I just released the front, and maybe they had, tightness in those areas, but there's something in the back that needs attention. Now, a little anatomy. This is an area, I came up with those tests personally myself for the hip flexors. I met a physician who does regenerative medicine. He does, if you haven't heard about that, prolotherapy, PRP is plasma-rich protein injections. They also do other things, hydrodissection, all that. But I'm going to stick with the injuries in the back are very common. Physicians are finding micro tears, and the athletes are going to be part of this group from training, but also from falling on a hurdle or just falling on the track or whatever. Certainly football, they're always falling. There's tears in here that are unidentified, and people just don't know about these things. So unless you do. So if you look at the lower right-hand image, the right side has the lat intact. I removed visually the lat on the left. You can see a fade through the lat. Now the yellow would be the longissimus thoracis. Well, it's not just thoracis. It goes from thorax all the way down to your sacrum. That is how long it is. So if you have a problem down below, it can create problems above, and you have problems above, it'll create problems down below. So we have to identify these areas where they have common tears right down by the sacroiliac joint. And I'm going to talk about a specific area. The next picture on the left is the iliocostalis. What is iliocostalis? It goes from ilium, as you can see, and it goes to costalis. Costalis is the Latin word for ribs. So it goes all the way up to the ribs. So again, is it an upstream effect, downstream effect? All is affected negatively. Now, if you stay with me here and look at this iliocostalis, to the left of that is that white tissue. That's the fascia of the TA, transversus abdominis. Next would be the internal oblique. And then finally at the outer edge is the external oblique. Well, they're looking at the image, my dear. Okay. So where the transversus abdominis is next to the iliocostalis, the physicians are finding tears. And where someone falls on their butt, and most of us has fallen on our butt at one time or another, but something is still not getting better and they still have chronic pain in these areas or chronic decreased performance after a fall, there is most likely a tear. And so we need to be able to test that out. So what I will do is, well, I just want to show you this. Omnidirectional, this is all these arrows that you see on the left on the cadaver and on the right on the image. All these arrows that you see, I don't even have my cursor working, but they show the direction of tension, again, that Bill Parisi was talking about. It's a tension system, it's tensegrity. So the push and pull of the body, the compression tension cannot work right when there's a tear. It automatically weakens the system. And so we have to be able to do something about referring them to the right person or maybe figuring out if they have a tear or not. And you can do this actually without an MRI. But they're going to be at risk for micro tears, fraying, and disruption. That decreases force transmission. So what I do is, and this doesn't quite show it, I have my whole hand on their back. I will take my 3 fingers again, and I will put it right there where the iliocostalis meets the sacrum or the transversus abdominis. I'll test these areas, and I'll keep my 3 fingers with 1 pound of pressure or whatever it is, 500 grams if you use grams. And I'll put them in that leg lift position. And if I can't push down, I know they have a tear right there because I temporarily supported that tear. It feels intact. It has tensegrity now, whereas before it didn't. When I take my fingers away, they fail the test. When I put my fingers back on that area, like it's tape and it's supportive, they can hold. It's incredible. And it's like I just confirmed, you need to see probably a regenerative medical doctor. So in the upper right-hand corner, when they get a 5 out of 5, they test strong. My hand there, because I found the spot, I will send them to a regenerative medicine doc. They do prolotherapy, PRP. They will confirm the tear on ultrasound imaging, and sure enough, 9 times out of 10, that's what it is. And there may be other tears, but you know, everyone is a win-win. You feel good because you got it right. The doctor feels great because they're working with a great practitioner. The client feels amazed that they have a team that's on their side. And basically the athlete's at the top, or the client, if they're not an athlete, it's about their story, what's going on with them. And we are the people that are going to support that, but we need to talk to each other. That's the arrows. The therapists need to talk to the coaches, who needs to talk to the medical staff, who needs to talk to the coaches. Not every day, but we need some kind of communication so we're all on the same page, because we all hear different stories, right? The athlete does not tell everybody everything, and you start hearing other things from other staff members. You know, when you work together as a team, okay, we got some other things going on, and sometimes it's psychological, right? So we'd like to invite you, if you're interested, to check us out at stretchwin.com. Marlene was trained there. If you want to know what FST is, see Marlene, get on Marlene's table and experience it, because she's at the top level with level 4. She knows what's going on with it. And that's it. I want to thank you again. And any final words?
No, you did it.
Want to invite anybody?
Well, if anybody's got any questions, we'd be delighted to answer them.
All right, let's check the chat here.
Close that share. How do we stop the share?
And we are opening the floor to any questions. So if anybody has any questions, speak, raise your hand, type a note in the chat.
Well, I see Miss Paws has made the point that Pasha has entered the chat. I like her comment.
Oh, thank you.
All right. Well, thank you, Ed and Chris. Yay. Thank you for coming out. We shall meet again soon, I'm sure. And thank you for that awesome presentation. Now, I am so excited.
Marlene, sorry. One question from Piran Brown.
Oh, okay.
Right. She's asking if they use kinesio tape techniques before or after their partial stretching.
You know, that's a good question. Thank you for that question, Dr. Brown. Kinesio tape is really, you know, kinesio tape, rock tape, the taping, elastic tape is really good. When I do my testing that I just talked about, and I think there's a tear, I sometimes will tape it in a specific direction of line of force, and I will retest the muscle, and it's amazing sometimes how it just gets strong. It's like, well, I'm not on the ligament, I'm not that deep. It's just amazing how taping can work to support. And so that will help my, you know, physical therapy diagnosis or assessment. And it's also something you can provide the client or the athlete, at least temporarily. They feel safer, they are safer, they can do certain training with precautions so you don't increase the tear. So yes, we do use it at the right time and place, yes.
So what do you think accounts for the immediate benefit though? Is it that a neurological benefit or is there more?
I think it's a little bit of both. I think a lot of it's neurological.
Proprioceptive.
And proprioceptive for sure. Because I did it on an AC joint that's got separated on a linebacker, and I could push his arm down when I did a muscle test without tape. And I taped that at 100% tension, like a star in every single direction. And I tested, he was strong. I'm like, it's on the skin. It's not on the ligament. How is this possible? But I didn't say it to him. I just said, good game.
I just made a point that Piran Brown, she's actually our resident kinesio taping instructor.
Oh, okay. Okay, great.
Nice.
Thank you.
No further questions, Diallo?
Not seeing any here.
All right, awesome. So like I was saying, let us move on to our last and final speaker, who is a trailblazer in movement science. Mr. Andrew Frankson, he is the creator of muscle fiber methodology and an inventor of the LAD. The initials is LLAD, and it stands for Lower Lateral Alignment Device. Now, Mr. Frankson, he graduated from the prestigious Connecticut Center of Massage Therapy as a clinical massage therapist and is a personal trainer. Now, with a deep understanding of biomechanics, Andrew has developed a system that enhances athletic performance and recovery, which is detailed in his book titled Muscle Fiber Methodology. He also provides the alphabets, but it stands for the National Certification Board of Therapeutic Massage and Bodywork approved continuing education workshops in the United States, here in Jamaica, Barbados, and Trinidad and Tobago. He hopes to travel the world teaching his methodologies. You guys, let's welcome Mr. Andrew Frankson. Take it away, Andrew.
I seem to be breaking up here.
Yeah, I think we were frozen for a second. There you go. All right, Andrew, I think you're ready to take it away. Did you hear my great introduction or did you miss it?
I heard a piece of it.
Okay.
But I can work with that. I can work with that. So muscle fiber methodology, what it is. So muscle fiber methodology is a combination of passive stretching methods and clinical muscle fiber manipulation. Now, how this came about, I looked at the body in a different way by using basic theories. I haven't changed any theories. I just work with the basic theories that have been out there forever. Now, all of us have muscle imbalances, everyone. And the main reason for this is because we all have a dominant side. So, if you're right-handed, you naturally lean to your left side to support the movement that you do with your right. Over a period of time, what happened is that with the right side, we elevate our right hip and right shoulder while compressing everything on the left side from the hip down. Are you hearing me, Marlene?
Yes, sir.
You know, we're here.
Okay,
You're
okay,
good.
just checking.
Yeah,
Just
okay.
checking. So because we have a dominant side, we tend to lean to one side more than another, shortening muscles accordingly. Now, I created passive stretching and clinical massage manipulation to help the body to correct those imbalances. Like, for instance, a lot of people develop a lot of neck issues over a period of time because of a dominant side. So with simple passive stretching, and when I say passive, I mean straight passive, where something or someone does the stretch for you. Now, within the passive stretching, we work with basic sensory organs, and there are two main sensory organs, the Golgi tendon organ and the muscle spindles, which are found in all the muscles. Now, with the muscle spindles, if you stretch your muscle too far, this sensory organ sends signals to the brain, which in turn, the brain sends back signals to tell the muscle to contract. So when you're stretching and you feel the burn, you're doing the opposite to what you're trying to accomplish. You are now creating a stretch within a muscle that you are stretching too far. So this is where we start working with the client's end feel. Now, when you work with the client's end feel, you will not fire up the sensory organ, the muscle spindle, that is going to create the opposite effect to what you're trying to accomplish. So the training that I create is working with the muscle spindle and the the muscle spindles, and the client's end field. Now, those who have come to my past classes, they realize how subtle and simple these movements are. Less is more. Once you work within a client's end field, the more relaxed the client is, the quicker the muscle releases. And this can be done with any and every muscle in the body. Now, with passive stretching, once you elongate the muscles, everything, tendons, fascia that's attached to it will relax and elongate also. With clinical muscle fiber manipulation, same thing. Once we manipulate the muscle fibers, we are also manipulating any and everything attached to that muscle. Now, why we talk about muscle fibers is because with the muscle fibers, or with each muscle, different fibers do different actions within a muscle. In other words, one muscle does more than one action. So depending on how you use your body, certain fibers within a muscle will be tighter than others. So in muscle fiber or clinical muscle fiber manipulation, we manipulate muscles according to its actions so that muscles relax much quicker. So within a session, the client that you're working with or the professional who has learned muscle fiber methodology will see a change long before the client even gets off the table. The client themselves will feel that change long before they even get off the table. So muscle fiber methodology is unique in its way where we really do assist in helping the body in correcting muscle imbalances. One of the things before we even start touch the client, we assess the client to create a treatment plan. Now let me break down assessment because that can trigger certain people to become defensive. As I was told by a friend of mine who's a doctor that during her training, the word diagnosis and assessment were interchangeable. And this is where some professionals will find a problem when I say I assess my clients. Now, when I say assessment, I am looking at my client. So because of my background in knowing the muscles, their attachment, their actions, I can determine which muscle is impacted by a certain pattern, by how a client sits, by how a client stands. Now, during this assessment, which I normally do in a lot of my passive stretching workshops, I like to pair up my participants and have them assess each other accordingly to what they think an assessment is. And it's always good to see these professionals, these physiotherapists do their thing. It's always fun to see them at their best. But then when I get to them and just look at the client and come up with other assessment that they would have missed just because how detailed they might want to get into it. Now, the reason why the assessment is important is that most clients, when they go in for massage or to their doctors or PTs, they would fill out an intake form. Now, sometimes the clients will forget something. Now, if we as trained professionals are looking at our clients and seeing these imbalances before they even open their mouth, write down anything, if whatever we see is not on that intake form, we can now then say, well, I noticed that you have an elevated right shoulder, but you also now have an elevated left hip, which naturally, if we are right-handed, it should be an elevated right shoulder, elevated right hip. So this is where we ask the necessary questions. Now with the elevated right shoulder and elevated left hip, the possibility exists that this client can develop scoliosis, or they might already have scoliosis. Now with this assessment, we can now refer this client to their doctor or a friendly neighborhood physiotherapist for proper diagnosis. So when I say assessment, I'm just looking at the person. So with proper assessment, I can know, and a number of my students who have done all the courses, both the basic and the advanced courses, we're able to create treatment plans that can start assisting our clients with rehabilitation and prevention while relaxing the client. And one of my main things is the prevention aspect of it. Because with every imbalance that the client might have, they will create other imbalances in other parts of the body. Going back to a person with dominant right hand, elevated right shoulder, elevated right hip, they will be compressing the deep butt muscles on the left side and everything on the lateral side of the left leg, including piriformis, which might lead to sciatica, aka piriformis syndrome. So knowing the muscles and assessing a client effectively, we can refer and we can create proper treatment plans accordingly to assist the client while they're with us and guiding them to their doctors or whomever for a diagnosis. So prevention is one of my key things that I'm all for, especially when it comes to athletes. For every sport, we can tell what muscles will have an imbalance. Once there's a dominant side, depending on the sport, how the client uses their body, they will develop muscle imbalances in certain muscles. With that in mind, with the application of any therapy, including muscle fiber methodology, we can assist these athletes in protecting themselves from these imbalances so they last longer in the sport that they're participating in. So I am all for prevention. Rehabilitation, muscle fiber methodology is perfect for that also. I've created different protocols to deal with hamstring issues, quad issues, calf issues, and most of these protocols, they work. Up to yesterday, I worked on an athlete that will be performing next week or this week at Boys Champs, and one session, he was pain-free because of some simple protocols that were applied yesterday. So, not to brag, but muscle fiber methodology works if applied effectively. And this is something I want to travel and teach worldwide. Now, as an NCB-TMB board-approved continuing education provider, all of my CE classes are recognized internationally. Every CE that you take with me, which I teach 6 CE workshops, There is the passive stretching and the clinical muscle fiber manipulation workshops. Now, these two workshops are the basic workshop will show you how to do the stretches and how to manipulate the body using the techniques that I created. Now, most of these techniques are done with the therapist sitting down. So we're manipulating the entire body while sitting on a rolling stool, sliding around the table. Now, what this does by working on a rolling stool, it protects our hands and other soft tissue injuries. It protects us from it by replacing muscle strength with body weight. So normally when we, most therapists were taught to use horse stance, bow stance, forearms and elbows. With muscle fiber methodology, all of that is eliminated. The only thing I use is my hands. And I've been doing massage for 30 years, and I have no issues with my hands. Most therapists, before they leave school, they damage their thumb. They create the Quervain syndrome because they use the tip of their thumb most of the time while working. That pressure puts a lot of, it inflames at the joint at the bottom of the thumb, which creates a lot of problem. So in turn, they go and learn forearm work. They use a lot of elbows. And in my opinion, because there's not much nerve endings in these areas, most of the time we don't know how deep we're going in a client. And sometimes that depth, instead of the client relaxing, they're tightening up on our tables, which is creating other issues in other parts of the body. Now, when we use muscle fiber methodology, we are targeting the muscle fibers according to its actions. So we'll be moving the appendages in different angles to target different fibers. So it's a very detailed and specific method. Now, in the advanced classes, after I trained the passive stretching and how to break down the muscle, I was asked, why not teach the theory first? But the theory is more detailed. In the advanced classes, we look at more diagnoses and how to use passive stretching and clinical muscle fiber manipulation to help the body correct these imbalances. Like, for example, there's somebody's diagnosed with torn ligament in the knees. Muscle fiber manipulation cannot do anything for torn ligament. But the client with that torn ligament, say the right knee, they're going to be elevating their right hip, right shoulder. They're going to have a twist in their hip because of the elevated right hip, creating an anterior tilt on the right side and a posterior tilt on the left, creating a twist in the hip, throwing the pelvis off. Once the pelvis is off, then back pains, shoulder pain, pelvic pain, all kind of pain can start developing because of other muscle imbalances that diagnosis will create. There's also, I'll say, carpal tunnel syndrome. Now, one of the questions, because a lot of the theories that I use for muscle fiber methodology is from Whitney Lowe, which I respect him as an orthopedic specialist, and his books are right on par. So all of the information that I use when it comes to the theory is from his books. Now, when it comes to carpal tunnel syndrome, the question I would ask, is it true carpal tunnel syndrome? Because the same nerve, the median nerve, can be compressed right here on the arm at the muscle called, it's beating right now, but my muscle that is called pronator teres, my bad. So the median nerve can be compressed at both attachment sites of the pronator teres, and that is called pronator teres syndrome. Now, at those compression, it will refer pain to the wrist. Now, as a clinical massage therapist, I would not just work the forearm muscles, because that same nerve can be compressed at anywhere where it comes out of the cervical spine, down through scalenes, under the collarbone, under pec minor, coming down into the arm. So working the entire chain would be more important than just focusing on just the wrist. Because the nerve can be compressed and anywhere in that chain and refer pain to the wrist. Even if it's carpal tunnel syndrome, that diagnosis, we still need to treat the entire chain to make sure that we're breaking up other imbalances within that chain. So with the advanced classes, it's more detailed, which I've had a few students that have gone through it, and they have practiced how to use the basic methods in correcting these imbalances. So with muscle fiber methodology, we can assist with a lot of imbalances when it comes to rehabilitation, and we can definitely help the body to prevent other imbalances from happening within the body. Marlene, how much time do I have there?
You are at about 4 minutes left, sir.
Okay then. So, muscle fiber methodology, we deal with imbalances. We love to rehab, we love to prevent. And doing all of that, we have to relax at the same time. Now, there's a lot of other modalities out there where people might ask me what I think about them. And my answer would be, everything has its place. With muscle fiber methodology, we can assist with almost every imbalances that might be developed in the body. By manipulating muscle fibers, we can assist with tendon issues, fascia issues, and just lengthening and relaxing the muscle at the same time with just simple manipulation of the muscle fibers. We spoke about dominant side. We all have a dominant side, so because of that, we all have imbalances. So we focus a lot on athletes, but our everyday worker, they all have imbalances. They all have something going on. We need to start addressing our everyday weekend warrior, sit behind the desk person, gym junkie, because they increase on these imbalances that is going to create problems for them in the long run. So we need to start educating the population on a whole about correcting or preventing certain imbalances because of the jobs that they do or how they use their bodies on a regular basis. So we can go into the discussion now. I love to answer questions. I'd like to go in more details instead of just keep talking. I didn't have any file setup, because I believe in face-to-face training where the participants see practice, but most importantly, they also feel what it should feel like so they know what their client is getting.
That's right. Awesome. Awesome. Always great to hear you speak, Mr. Andrew. I love it. The passion, it just spews through you. I love it. We will take any questions we have for Mr. Andrew. You can type the question, join in on the chat, or raise your hand. Any questions we have for Mr. Andrew? Okay.
Well, I'll ask one question, if I may.
Yes, absolutely.
Yes. All right. Yes, Mr. Andrew. I don't remember if you mentioned it, but I did. I remember from your stretching course, your passive stretching course. One thing that you highlighted was, and which really stood out to me, was applying the stretching and applying a circular motion. And I'm just thinking about that now, and then coupling that with Bill's presentation earlier, the whole multi-directional movement and so on. So, do you see a connection there between your stretching technique, that circular motion, and the whole multi-directional training?
Yeah, so with the rotation aspect of things,
Right.
now the body is designed to do three main actions: flexion, extension, and rotation. Flexion and extension, running, walking, sitting, bending, but we're also designed to rotate. Now, when you add rotation to the movement, rotation encourages every muscle that does flexion and extension to relax to support the action. So rotation is a lot. I do a lot of rotation, but you need to be mindful of the client's end feel also, working with their muscle spindle. Still, if you are stretching the muscle too far, you will create the opposite effect. So you still have to be working with the client's end feel and muscle spindles. If that answers your question.
Yeah, I think somewhat. Especially with the rotation. I guess with the rotation now, you're going beyond the sagittal plane.
Yes, definitely.
Right. So I'm seeing the connection.
Definitely.
Correct. Yeah, definitely see the connection there. All right, great. Thank you.
No problem.
Awesome.
Open to other questions. Not seeing any so far.
Give them a few seconds. All right, I think we will move on. So I just wanted to say thank you to all of our esteemed speakers for sharing their knowledge and insights and expertise. I think we had a really great understanding, at least foundational, about what you guys are proposing. And so as we transition into our panel discussion, I'd like everybody to stick around and share, because what the topic of our thing was, are we too focused on muscles, and can fascia be a missing link? Because for years, personal trainers, physiotherapists, all of us have really been strength and conditioning coaches. We have been very well muscle centric, right? And we focus on isolated movements, hypertrophy and strength gains, and that was kind of our thing. However, as we have just heard from all of our presenters, that there may be some other link that we're missing to integrate this entire system, and can play a significant role in movement efficiency, injury prevention, and athletic performance that we had previously thought. So to answer that question, I would like to open it to our panelists, which were our speakers, to say, first question is, are we too focused on muscle, or should fascia take the center stage in our training modules? I can either guys, and I'm sorry that Chris and Ann had to leave. They had a family gathering, so we have Mr. Bill Parisi and Andrew Frankson here to share in our discussion. And either guys can start first. I don't know.
Okay, I'll start. So go ahead then.
No, Marlene, can you just, I'm sorry, repeat the question?
So the question was, are we too focused on muscle, or should we be taking or being more focused on fascia or in our training methods? I mean,
Yeah, I would start off by saying it really comes down to the individuals that you are working with, right? I mean that when you say too focused, well, maybe someone if they're young, and they're very weak, they might have a deficiency in muscle strength. So they will need compound type movements, sagittal plane movements to build a foundation, to build an engine. So, depending on the individual, what their training history is like, what their strengths, what their weaknesses are like, what their movement history is like. How do they live their lives? Meaning, do they work on a farm, or are they in the office? Are they a student? Are they sitting a lot? Or what are they doing in their spare time? All these things play a role in determining what someone needs and what they might need or might not need. So I think we have to assess the individual first, their training history, their training age, what exactly they've been doing, and then we can answer that question.
nice, understood. Is that Mr. Frankson?
Yes, what he says make perfect sense. Just targeting one aspect only might not be beneficial depending on who that individual is. Because of how I work, where I target muscles, the reason why I do that is because everything is attached to the muscle, or the muscle is attached to one thing or another. So targeting the muscle, in my sense, will also target any and everything that's attached to it. But I see the importance of making sure that the fascia is where it should be, to make sure the entire body is working as one unit.
Yes, good deal. Understood. I get it. I get it a lot. That was pretty good. So I'm gonna get a little bit more detailed. Now, Bill, we'll start with you. Why not? Based on your techniques that you have been using in your training system, what are some of the key areas of focus in the recent research? Or let's say, to put it in another way, how is the research evolving around your techniques?
Yeah. Well, I think one thing is really understanding the spine and understanding how to manage spine mechanics, and keep a healthy spine, which leads to the pelvis and pelvic positioning. This is all crucial in training and keeping tissue healthy, and optimizing performance for all types of people. Your average person, in the workforce compared to, as well as the athlete. So I feel the biggest issue I know in America is back pain. Back pain is a massive, $100 billion is spent on back pain. And it's not that complicated. I've worked with surgeons. I worked with the top biomechanists, in the world. Someone like Stuart McGill, who's published over 250 peer-reviewed research papers on back pain and core stability and prevention and rehabilitation. And it is highly preventable and manageable. And it comes down to spine hygiene and managing your movement literacy and owning your spine and movement hygiene. So it starts there. You know, an area I've taken a lot of focus in the last 10 years going down the fascia road is spine hygiene and understanding the spine, the connective tissue of the spine. When you look at the vertebral discs of the spine, it's a massive challenge for many people because your discs, for some people, their discs wear out, and they wear out not only due to age, but poor hygiene, poor postures, and poor lifting mechanics. There are athletes in the US, I will not mention, that have earned well over $100 million or more that have unfortunately poor lifting mechanics and injured their backs. And they've injured their backs because of improper advice and coaching. And when you look at the vertebral discs, what the discs are made of, they're made of collagen. They're made of quote unquote fascia. It's called the annulus fibrosus, the tissue that surrounds the disc. Inside that disc is the nucleus pulposus. So that separates the vertebrae, and it's a shock absorber. And managing spine hygiene and understanding that tissue can be regenerated, can be fixed. A lot of times, you know, believe it or not, without surgery. If you closely manage spine hygiene and positions, this is proven by Dr. Stuart McGill. You can do the research. You can Google Dr. Stuart McGill. You can get his book, Low Back Disorders, which is a textbook for most physical therapy students that go to schools that prescribe to his methodology. So the point I want to make with all this is I did a deep dive into spine hygiene and pelvic positioning because those areas are the engine to and the centerpiece to force development. Those have to be aligned, they have to be trained, and they have to be supported by all the dynamic stabilizers for you to be able to maximize force output of the hips, of the glutes, of the hamstrings, the hip flexors, to get the body to maximize locomotion. You have to have sound postures and sound stabilizing muscles to be turned on when they need to be turned on, and to be turned off or calm down when they need to be calmed down. And those transitions happen in milliseconds. Those transitions in movement, muscles are always, you know, turning on and relaxing, you know, dynamically in milliseconds. And that neurology of being able to have muscles, you know, activate and relax and activate is a skill that can be learned. And the great ones, the ones that are breaking world records, have an innate skill and it's basically their nervous system that allows them to kind of, you know, turn muscles on and off. But to answer your question and bring it back down to to a much closer view here is, you know, we put a lot of focus on spine, understanding the spine and managing spine health is a big part of what we do. And power generation is really generated and managed through the core. Because if you don't own that area, you're doomed for disaster.
Definitely understood. Mr. Andrew, I would pose that same question to you then. And I'll repeat. It says, based on your specific technique, what key areas of focus are in the recent research? Or is there what is the research evolving around your specific technique?
Okay, so I worked with a physiatrist in Connecticut for 7 years. I've seen every muscle imbalance that you can think of. I've worked with all imbalances out there. when it comes to muscle. And what I realize is that with proper maintenance, that we can help to eliminate or rehab or prevent a lot of these imbalances. So most of my research was from my years of experience with the physiotherapist and also applying my methods also. So when it comes to the spine, in my opinion, because we have a dominant side and that throws everything off, no matter what sport you're in, what kind of job you do, focusing on the muscles that can be shortened because of how we use our body. Now, the muscles are designed to contract, relax. How we use our bodies, the muscles tend to contract, contract, contract. But most of us do not stretch. I am a big believer in stretching, especially passive stretching. So to incorporate stretching in our daily routine, we can help to eliminate a lot of imbalances that can develop because of how we use our bodies. So retraining the muscle to contract, relax by just adding stretching, especially passive stretching, where you are relaxed, doing nothing, and something or someone is lengthening your muscles for you. Because other stretches other than passive stretches is active stretches where you shorten one muscle to lengthen another, which those stretches are good, don't get me wrong. It's a good thing to actively stretch your muscle. But if you can find the time to get your muscles passively stretched, it will be a bigger benefit for the entire body. So that is my thing when it comes to how we should treat our body. A lot of these athletes that are lasting longer in their sport, most of them travel with a massage therapist. Right after their heavy training and all of these corrective things, they get their muscles stretched and relaxed immediately after. So they recover much quicker without taking anything, or they just rely on their therapist to do it for them. So the importance of proper manipulation or effective manipulation of muscle fibers can have muscles rehab much quicker.
Understood, understood. Now I am not so much of a passive stretch person. I am a more of an active assisted stretch specialist. And so we may differ in our ideologies just a bit, but I would venture to say that sometimes that with passive, I mean, it depends on what the goal is, right? So with passive stretching, allowing somebody to do that technique on you is very relaxing, very calming. But if I want to engage and try to understand where there are imbalances specifically, even felt by the client, you know, we can't feel what the client feels. So when we integrate this active part of our stretching, we get feedback from the client as well, as in addition to the tissues itself. So we may differ a smidge bit in passive versus active assisted stretching, but I do value your opinion.
No problem. We can agree to disagree. I love it. This is how,
yes, sir. Yes, sir.
This is how we get better, because what this would translate to is a happy client. And it's not about us, but the client that we are assisting out of pain and to prevent them from going into pain.
That's right. That's right. Awesome. Thank you so much. My last question I will pose to each of you, again, we'll start with you, Mr. Bill, is that if you can just please take 1 or 2 minutes and just share about why your technique would be valuable to professional growth, whether it's, you know, therapists, athletes, the gamut.
Well, I think fascia is not understood at the level it needs to be across all fields of not only physical therapy, but sport coaching, even many in the medical world. I've done dissections. I help perform dissections of fresh cadaver for many individuals, from NFL strength coaches to professional coaches to medical doctors and surgeons, to really help them understand this connective tissue. So it's not understood because for 500 years, anatomists and the medical community have thought that fascia was simply a packing material similar to what you find in boxes to hold things in place, like bubble wrap or the popcorn inside shipping boxes. And it had no real use except to hold organs in place. But now we know it's much more than that, because recently, and as recently in the last 20 years, of ultrasound equipment. The ultrasound technology has been advanced so much that now we know fascia is the largest sensory organ in the body, larger than the skin. Its communication network is the most valuable communication network in the body. It's the system that ties it all together. We're just learning this. So I believe we um, are at a point of breakthrough in terms of understanding how to reduce risk of injury, and starting to understand the body as a biotensegrity system to build more resiliency. Like I said before, you know, understanding how to apply unpredictable stress. And let me say that again, understanding how to apply unpredictable stress to the body. When we lift weights, that's predictable stress, like lifting exercises, squats, bench press, deadlifts, lunges, predictable stress. How do you apply and manage unpredictable stress to prepare for sport, which is highly unpredictable? And we do that with our training methodology. So I feel that is the big breakthrough, managing and really what we call in dynamic systems, uh, providing a constraints-led approach, CLA, adding constraints in a way to an athlete that's unpredictable, that causes that athlete's organism to self-organize, to respond to these stressors without thought. And this is called a bottoms-up approach, because skill acquisition happens in really two ways. One, a top-down approach, which is a cognitive approach, which we learn about a skill, we start to see it, we think about it, we think about certain movements and techniques, so we internalize it and we adapt that skill. That's a top-down approach, that's a neural pathway approach, that's a motor engram approach. Another approach to motor learning through Nikolai Bernstein, a Russian scientist in the mid-1900s, or I should say the mid-20th century, in the 1950s, started to come up with the concept of dynamic systems and really understanding how to adapt skill without thought, but through trial and error, and really using the environment to help the body self-organize. And it's a different approach, which is very viable. And I believe the fascia system plays a massive role in the body's ability to understand the environment, to adapt to the environment in milliseconds, in really where the signals don't even come up to the brain or even the spinal cord, where the signals are more local in the local joint systems, to create co-contractions, to create pulses of stiffness and stability within that joint, pulses of milliseconds that manage the degrees of freedom that we have. It's what we call a degrees of freedom problem, which Nikolai Bernstein has made famous, because we have hundreds of joints in the body with hundreds of positions that we can be in. How does the brain manage all these joints and all these possible positions in milliseconds of sport? It can't. So there has to be local signals and local impulses of contractions to stabilize joint systems, to allow for joint stability in milliseconds when our foot hits that divot. That's why running barefoot on uneven surfaces is incredible training without thought. Without thought, where that ankle joint system is responding to all these uneven surfaces locally to create stability in that system. So there's things that you might not have a perfectly manicured field or track, and some ways that's a disadvantage, but in some ways that is an advantage.
Nice, nice. That's very true. Mr. Andrew, I share that same question with you. Should I repeat?
Yes, please, because
Yes.
I was having some technical difficulty.
Oh, no. Okay, okay. So in basically 1 to 2 minutes, I would like for you to share with us about why your recommended technique would be valuable for professional growth.
For professional growth?
Yes, sir.
Okay, so for professional growth, we're looking at applying the methodologies to prevent and to rehab. So as I said earlier, which I agree with Bill in a lot of sense, where fascia plays a major role in how the body moves, how the body responds, and the body's a beautiful thing. Always muscle methodology, looking at this one particular beautiful red stuff in our body that does this massive movement, targeting the muscle will also translate into targeting everything else. So if we're able to prevent a lot of these imbalances from happening by applying fascia work and keeping our muscles long and lean with manipulation, we'll be able to help our athletes and everyone else to stay much healthier and keeping them away from unnecessary muscle imbalances. Now, there will be trauma. There's trauma all the time. So we can't escape from that. There will be trauma. But the other stuff that we can prevent, like for instance, in a lot of runners, they have hamstring issues. Now, the main hamstring muscle that develops muscle imbalance, that develops imbalances, is biceps femoris. Now, other than just an extensor of the leg at the hip and a flexor of the lower leg at the knee, it is also a lateral rotator of the leg at the hip. And when I say lateral rotation, once you sit with your knees apart, that's lateral rotation. So constantly, if you're in a car, sitting at a table, which we sit with our legs apart for balance. So constantly doing that doing that on a regular basis, we are always shortening biceps femoris. So as an athlete, if you drive to school or if you're in school, you're sitting behind a desk every day, and we just get up and not stretch and we go into our training, we are now compounding biceps femoris by shortening the muscles more, which will, in the long run, create a situation where this athlete can have a torn hamstring muscle. And most of the time it is biceps femoris. So because of that fact that we know, we can help these athletes prevent a problem like that from continuously stopping them from being the athlete that they were designed to be or meant to be.
Understood, 100%, definitely. Listen, that was my last question. I just want to say that I loved it. You guys, you, Andrew, Bill, and Ann and Chris are like my role models. So I'm so thankful for you guys to show up and show out today and help educate our community. Yeah, I will now turn it over to Ms. Ashley, who will give us a conclusion and basically a wrap up. Thank you all so much. I appreciate you.
Arlene, sorry,
Yes.
there is a question on YouTube that somebody asked. Miss Denise Allen Blair is asking if acupuncture or dry needling has any place in fascia manipulation. I guess Mr. Parisi would could answer.
Yeah, well, it does. I would say, you know, obviously dry needling, a big aspect of dry needling is to help relax trigger points, right? So a trigger point is a hypertonic patch of muscle that the muscle's in a spasm. And the muscle spasming could be to a lot of different reasons. So, you know, fascia and muscle are intertwined, right? It's called myofascia, you know, muscle fascia intertwined. And that hypertonicity to a muscle is being signaled you know, through the fascia. So they're both kind of intertwined as one unit. The thing is, we only been talking about muscle for the last 500 years, and haven't really addressed the stuff that's encased in the muscle. And how I like to describe it, the muscle cell is really a water balloon, and inside the water balloon is all the, you know, the muscle fiber and, you know, the nucleus and the mitochondria and all the elements of the cell. That's inside the water balloon. The water balloon itself, the actual, that's the fascia. That's the fascia. So it is, and now we know that fascia, that water balloon has a lot of neurology in it, a lot of neurology, a communication network. So yes, the answer is yes. Those techniques absolutely address, because it's the fascia is intertwined into the muscle. It what holds the muscle together. Without fascia, the muscle is a blob of chop meat.
Thank you so much. I hope that answers Miss Denise Blair's question. I think Diala also has a quick question.
Right. Hi. Yes. Yes. Thank you, Jody. I'm not sure if anyone else has any questions. I will defer to them first, but if not, I'll go ahead. Right. So my question is for both of you, both Bill and Andrew. Bill, you spoke of training age, but what about chronological age? Does that change, both of you? Does that change how you see things? So, for example, Bill, with aging, of course, there's sarcopenia as a concern. Do you then think of muscle as being more important in that case? Or Andrew, in your case, with aging again, collagen gets tighter, joints get stiffer, and so on. Do you then think of fascia more? Does it change other of you guys' approach with aging?
Absolutely. I mean, you got to look at, obviously chronological age is an automatic, right? You have to look at that, and training age. So they're both, to me, they're both equally as important. Like you got to know those numbers. And you also have to look, when you look at chronological age, you have to look at what has that person been doing for the last number of weeks, months, and years. What have they been? How have they been living their life? What's their occupation? Are they a student? How often are they sitting? How do they sit? You know, what kind of positions have their bodies been in? Because, you know, if you take a long car ride, or like Gil Henley was showing on his video that I showed before, if you're in a certain position for a long period of time, your body's going to build up this resistance, this internal, you know, fascia that's going to limit range of motion. So that's one thing we look at is obviously chronological age, and then training age, and then what have you been doing throughout that training age. So yeah, we have to look at all these factors, and we have to create a program based on what you've been doing, what your goals are, and what your, you know, what your limitations may or may not be.
Well, what about sarcopenia or trying to prevent sarcopenia? How do you approach that? in that case.
Can you describe that for me?
Sarcopenia, but losing muscle with age. I'm not sure if I'm coming across clearly. With
Yeah,
aging,
yeah.
you need to lose muscle tissue.
Yeah, yeah. So I'm sorry, it didn't come through the first time. I apologize.
Okay, no problem.
Yeah. So I think, listen, muscle loss, right, with age, typical is more due to less activity. Now, obviously, you don't have the hormones, you don't have the testosterone as you age, and that obviously limits your muscle growth and or maintaining muscle. But I feel as people age, they don't really have to, depending on what they're doing, they have to manage the impact, the speeds of different impacts. So you just have to lessen the types of impacts as you age. You can't perform the impact. So in other words, if you're doing plyometric training at a younger age in your teens and in your 20s, the amount of impacts or plyometrics or jump type training, you can't continue those intensities at an older age. But I will continue plyometrics at those ages, even into 60s and 70s, but they're much lesser impacts. We still need impact though, but it has to be toned down a lot. The body needs resistance. The body needs impact, but we can't be doing the types of impacts at 60 that we were doing at 20.
Right.
Because but we still need impact. And I think that's where we age faster than we need to in terms of not being able to move and function in an athletic way. And you can in your 60s and 70s and even 80s. My dad is 90. He's 90 and he still moves pretty well.
Right.
He still takes care of his garden. He still drives at night. He still does everything he needs to do because he's moving. Now, his impact might not be what it was when he was 60 or 40, but he still has some impact in his life.
Right. Great. Right. Thank you.
Okay, well, thank you all again. With no more questions to go in, my last announcement that we will be bringing in Miss Ashley. So Miss Ashley, take it over. Thank you.
Thank you, Marlene. It has really been a pretty insightful session, and I really learned a lot from these presentations. At this time, we want to take a moment to express our sincere gratitude to everyone who made it possible. And firstly, of course, a heartfelt thank you to our three presenters, or should I say 4 presenters, Mr. Bill Parisi, Chris and Ann Frederick, and Mr. Andrew Frankson, who shared their expertise, research, and clinical insights with us today. We've been challenged to rethink our traditional approaches in sports medicine and to also consider the role of fascia in rehabilitation, training, and performance. And of course, Mr. Frankson has reminded us to also keep the basics in mind. Your perspectives have certainly deepened our understanding of the topic and also left us with much to reflect on. To our attendees, we want to thank you for your engagement, thought-provoking questions, and active participation. This curiosity and willingness to explore new ideas is really what continues to drive the progress of our field. And finally, a big thanks to the JASM Education Committee, led by Dr. Jodianne Simpson, and with the support of our executive body, who worked behind the scenes in organizing and ensuring that this session ran smoothly. And also to our moderator for today, of course, Dr. Marlene Chin. Thank you, you did an amazing job. And as we close, we are implored to take these insights forward into our practice, continuing to question, explore, and refine our approaches in sports medicine so that we can serve our clients and our community. Once again, thank you all for being part of this seminar. So we have just one quick announcement that we have JASM branded items on sale. We have drawstring bags, caps, fanny packs, and keychains. So you can place your order with any JASM executive. All right. And also stay tuned for information on our next Keeping Pace session. So wishing everyone a pleasant rest of afternoon.
Goodbye, everyone.
Yeah. Take care, all.
Bye-bye.
All right. Bye, everyone. Thank you.
Bye.
Thank you, all the
For
presenters.
having me.
And bye.
Yep. Way to go, folks.